Hello, Roshni. Are you there? Hello,
Yes, sir.
Roshni.
Yes, sir. Good evening, sir.
The first speaker is Rajiv Bhattacharya. Has he joined?
Hi, sir. I am joined. Am I audible?
Yes, sir.
Fine.
Dr. Rajiv has joined, sir.
Okay, fine.
We have given the reminder calls for all the other faculty, sir. Faculty is being joined.
You are not so audible.
Sorry, sir.
You are not audible very much.
Am I audible right now, sir?
Yeah.
Roshni, good evening. I'm actually wearing my earphones. I just want to check if I'm audible currently.
Yeah, you are audible, Manjula.
Yes, ma'am. You're audible
Hi,
now.
hi, Dr. Rajkumar. Good
Yeah,
evening.
Fine. Good evening. Roshni, my video is not clear or is coming fine? Roshni, are you there?
Yes.
Is my video is clear or not clear?
Sir, your voice is little bit low for me.
Okay, my video is clear or not clear?
No.
Good evening, sir. Actually, your video is also clear. Can you please talk once again to like?
My video is clear or not?
Your video is clear, sir. Your audio is
The
also
phone
clear.
will be clear for you.
Hello.
Sir, your video is clear, and your audio is also fine only, sir.
Fine. Thank you.
It's 5:30, sir. Our first three speakers are with us. Could you start with the session, sir?
Yeah, fine. Start.
Yes, sir. So very good evening, everyone. On behalf of International Association for Integrated Oncology, IAIO, I warmly welcome you all to the today's Expert Insight session on breast cancer. We are privileged to have you with us, a distinguished panel of oncologists and breast surgeons who will share their expertise and perspectives on the latest advancements in breast cancer management. Now, I'm pleased to introduce Dr. Rajkumar Ramaswamy, sir, medical oncologist. Dr. Ramaswamy will be over to you, please.
Good evening, everybody. Warm welcome to the today's evening session on the controversies in breast cancer. I have chosen this topic very much on current controversies and debatable topics, so that we have a clear consensus how we do take these controversies and debates on these topics, pertaining topics in our clinical practice on our Monday office practice. So the first speaker is going to be Dr. Rajiv Bhattacharya, and he'll be talking on the neoadjuvant therapy in HR positive breast cancer. As we all know that the neoadjuvant chemotherapy in a HR positive HER2 negative subset of the breast cancer is they will not respond to the neoadjuvant chemotherapy with less than 10% PCR rates. And these neoadjuvant endocrine therapy was contemplated during our pandemic period when earlier it was used on the elderly, frail patients. Later on, during the pandemic, all the surgeons wants to postpone their surgeries because of the ongoing pandemic, and they introduced these neoadjuvant endocrine therapy in order to delay the surgery. And we have first-hand knowledge, and everybody gained some knowledge on neuroendocrine therapy. As we all know that the HR positive breast cancer is not a homogeneous subset of disease, is highly heterogeneous with the luminal A, luminal B, with varying Ki67, and the expression of the HR positivity also differs between high expression, intermediate expression, low expressions. And we know from our adjuvant trials that as well as in the metastatic settings, these variable expression of the HR positivity with the ALTRET scores varying more than 6%, less than 6%, do respond to endocrine therapy in a various fashion. As we all know that the neoadjuvant endocrine therapies, the earlier people are trying with the tamoxifen in elderly frail patients more than 70 or more than 80 years, and they are trying to achieve some kind of response in those subset of the patients, and the response rates are dismal if you use a neoadjuvant endocrine therapy with the tamoxifen as less than 10%. People are trying later on with the letrozole and the other forms of the ACRMs and SCRDs, as well as the newer drugs. Now we have the huge armamentarium of drugs has now expanded to include all the CDK4 inhibitors, PI3 inhibitors, and all. So what are the various trials which are shown? Dr. Rajiv Bhattacharya will show us, even though these are only phase 2 trials, and a lot of ongoing studies of the phase 2 trials are showing that the response rates are a little higher, but the duration, optimal duration of the endocrine therapy is still debatable. And what kind of response assessment you have to do for the assessing the HR positive HER2 negative subset, whether by imaging or ctDNA or genomic signature or Ki67. As we all know that the response takes a longer time, for long duration. What is the optimal duration of the endocrine therapy is required? We know that neoadjuvant chemotherapy is given in an abbreviated fashion of 3 to 4 cycles in order to downsize the tumor, but those kind of responses you don't get with the neoadjuvant endocrine therapy. You need a prolonged. People have tried with 1 year of and 6 months of neoendocrine therapy, but it has gotten a very pertinent danger of the progression of the disease also there. And we all know that the response assessment also requires various tools. We don't have the appropriate tool, an optimal tool to assess the neoadjuvant, whether it's by the PET-CT, MRI, or with the help of Ki67. This and all is very debatable points. And after listening to Rajiv Bhattacharya, we will have a clear insight on how to go about using the neoadjuvant endocrine therapy in a case of HR positive breast cancer. Over to you, Dr. Rajiv Bhattacharya.
Thank you, sir. Am I loud and clear? Yeah. So, yeah, I will, first of all, I thank IAIO for giving me this opportunity. I think this is my first time presenting in a very interesting topic. And I am Dr. Rajiv Bhattacharya. I am a medical oncologist at PLS Hospital, Kolkata. Today, we are going to discuss neoadjuvant endocrine therapy in hormone positive, HER2 negative, locally advanced breast cancer. So, the first thing first, when a breast cancer patient comes to us, we stage the patient, stage 1, stage 2, and then we get the biopsy. biopsy shows hormone positive, HER2 negative, we go ahead with surgery in stage 1 or stage 2. And when it's a locally advanced disease, in that case, what we do is we go for neoadjuvant therapy. But it is quite well known that in hormone positive patients, chemotherapy does not produce the extent of response that it does in a let's say a triple negative breast cancer or a HER2 neo positive breast cancer. So this is a unique situation where you have a breast cancer patient. The breast cancer is locally advanced, but also hormone positive with HER2 negative. So that's where our cage is. That's where we are going to stay during my talk. So these are the I have divided my talk into these few points. First of all, we have to understand what the rationale is of using hormone therapy over chemotherapy. We have to decide what patient population will derive the maximum benefit through this approach. Then we will go through very quickly, we will go through a few clinical trials, comparing various hormonal agents, comparing hormone and chemotherapy, and then we will see what holds us ahead in the future. Next slide, please. So this is the why neuroendocrine therapy. So the stage 2B to 3C, which is potentially inoperable, uh, some would say argue that 2B is operable upfront. But even in earlier stages, those patients who have small breasts but desire breast conservation, there you might try to use some sort of neoadjuvant therapy to downstage the disease to improve surgical outcome. And also, you want to see whether the disease is amenable to therapy or not. Does it disappear totally or not? So, our school, the book teaching we have read in our graduation days was in this situation, go ahead with chemotherapy, right? But we know that, as I was saying, that HER2 negative, HR positive patients have limited response to chemotherapy, and the pathological complete response rate, which in the TNBC is about 50%, is about roughly about less than 10% in hormone positive patients. So there you have a hormonal agent and you have a hormonal receptor, and you always try to attack the disease biology. That has been the philosophy of oncology. Long gone are those days when we would just use. Uh, am I audible? I think someone is finding me difficult to listen to. Roshni, can you just tell me whether I'm okay or not?
You're audible, sir.
Yeah, okay. Uh, someone actually commented. Okay, so that's why we choose neuroendocrine therapy, neoadjuvant endocrine therapy. We use because the chemosensitivity is low in this group of patients, especially in those patients who are luminal A type, very strong hormone positive, HER2 negative or zero, and those patients who are primarily driven by estrogen signaling. There, I think blocking the estrogen signal might give us good results. And also in elderly or frail patients who are not fit to tolerate the bane of chemotherapy, cytotoxic chemotherapy and its toxicities, there we can definitely treat those patients with hormonal therapy, which will produce much less toxicity. And uh, we are going to realize response rate by looking at not only at the shrinkage of the tumor vis-a-vis the imaging, but also the biological behavior of the disease, whether the AI67, which is actually a surrogate for an tumor, is or not with the endocrine therapy. Next slide, please. Next slide. So, who are the ideal candidates? So, we all know that hormone therapy would work better and actually the hormone receptors as a driving force mostly in menopausal, postmenopausal women. Also, we have seen that in premenopausal women, tamoxifen is not that effective. So in that case, usually with premenopausal women, we go ahead with chemotherapy, but in a postmenopausal patient, hormone therapy makes a lot of sense. A strong ER positive. So anything on score of 3 or more, we take it as hormone positive. But in for the this situation where we are going to use neoadjuvant endocrine therapy, there I think Aldred score of 6 or more is a good standard. That's where you derive the maximum benefit. HER2 status, HER2 negative, and even in HER2 positive patients, neoadjuvant endocrine therapy is insufficient. We mind you, this HER2 negative is not HER2 null, so we do not know whether HER2 IHC2 plus fish negative or there is HER2 low in the newer generation PDXT era, whether uh, HER2 low also portends a lesser efficacy to hormonal therapy. We do not know that. The trials do not venture into that space. Tumor biology, luminal A, sometimes B subtypes, and who have a low or intermediate Ki67, these are the groups that derive maximum benefit. Elderly frail patients, those who have significant comorbidities, so there is a negative uh, association with chemotherapy. They will not tolerate chemotherapy. I think these are the patients who can definitely try out hormonal therapy. And the treatment goal, if you want to uh, facilitate a breast conservation study of
Dr. Raji.
Hello.
I guess we lost Dr. Rajiv sir because of the connectivity. Sir has joined, sir.
some issue with
Yes, sir. Turn off your camera so that you could continue with your talk, sir.
Am I audible now?
Yes, sir. Yes, sir.
Yeah. So let's move on. And how much time do I have left?
Another 5 minutes, sir.
Okay, let's move on. Let's move on. I'll try to.
Yes.
Next slide. So let's move on to the next. Just quickly, these are the aromatic distributors that we have found out, and we know that inhibitors are better than tamoxifen. Now, duration of therapy, as a doctor has said, that there is a debate, but the fact is that the most commonly the duration of therapy is usually you get benefit around about 6 months duration, right? So most of the time they have used 4 to 8 months of duration of neoadjuvant hormone therapy, and some studies have shown that the maximum benefit occurs even after 12 months. So actually, hormone therapy takes a little bit of time to get its effect, and that has been shown in these trials as well. So these are the specific which have been used in 2001, the P24 trial, which compared letrozole versus tamoxifen in postmenopausal hormone-positive breast cancer. There, they showed that letrozole showed a superior clinical response and DCS rates, and hence aromatase preferred. In 2005, the IMPACT trial, they compared tamoxifen and anastrozole as well as combination of those two, and they show that there were combination confirmed response, and they showed that PICC7 did go down. PROACT trial in 2006, anastrozole they demonstrated higher clinical response than tamoxifen, even along with chemotherapy, and so it reinforced aromatase inhibitor superiority and neoadjuvant feasibility in disease. The OncoSoft Z1031 trial, they compared various AIs, including anastrozole, but steroidal AIs, and they showed no difference in response in terms of the AIs were concerned. All of them produced similar results. Also, they introduced the PAPI score, which was a prognostic score, and they deciphered whether the patient would require adjuvant therapy or not after surgery. I will get back to that later. And they were the first trial to develop a KI67 guided treatment adjustments. And NeoScent trial, that was compared the neoadjuvant chemotherapy with neoadjuvant hormone therapy, and they showed that they had similar VCS rates, but lower toxicity and fewer hospitalizations with NET. Neoadjuvant therapy can be taken at home. That's a big plus, I think. Next slide. For chemotherapy, you have to get
Dr. Rajiv, hello. Roshni?
I guess sir has disconnected, sir.
Mm.
Could we request sir and we'll take up the next session, sir, so that we can
Why
have.
don't you give a call? Why don't you give a call for him? Is he available on the phone?
Yes, sir.
I'm so sorry.
Dr. Rajiv, are you traveling? Dr. Rajiv?
Yes, sir.
Are you traveling?
Sir, I am on road actually. But I'm not traveling. I'm stationary.
No, you are going offline frequently.
Yes. Yeah. So I will try to finish it off very quickly. So these are the trials by Semiconov in 2017 that showed endocrine therapy compared to therapy and comparable, and when the level of estrogen receptor status was higher, you can say that all the response rates were slightly more when you gave endocrine therapy, neoadjuvant, than chemotherapy, and breast conservation rates were also higher. Next slide. Next slide. So the same trial where they showed that there was actual disappearance of the lesion in one few patients. Right?
Rajiv, you are going offline frequently. Hello, Roshni?
Yeah. Audible, sir?
Rajiv, you are off the line very frequently. Your voice is of low volume. Your video is not there. One thing I'll do, we will go for the expert opinion from all the panelists. That will be more useful interactive session rather than talking now. Okay. So Rajab, sorry, we will close you.
No problem, sir. No problem.
Okay.
No
Roshni,
problem, sir.
Stop sharing so that we can have a take-home messages from all the panelists. First, we'll go to Manjula Rao. Dr. Manjula Rao, you are there?
Yes, sir.
Yeah, you are the one who are going to operate on the patient. So you prefer to have a neoadjuvant endocrine therapy versus neoadjuvant chemotherapy in the case of a locally advanced HR positive HER2 breast cancer. What's your take on that?
In the current scenario, post-menopausal, premenopausal women, no doubt I would give them neoadjuvant chemotherapy. Post-menopausal patients, in those who are not amenable to neoadjuvant chemotherapy, that is when I would consider NAHP in them.
There are
The reason being, in a locally advanced breast cancer patient, a post-menopausal woman, currently there is no data to suggest that post-surgery, I can avoid chemotherapy in her. I anyway have to give her chemotherapy. So I might as well give the chemotherapy in the beginning, look for disease response, and then go ahead. Rather, unless we get a study which tells us that neoadjuvant hormonal therapy is definitely superior in these patients when compared to NACT, in patients with locally advanced breast cancer, until then, I would still consider neoadjuvant chemo. The only exception being elderly patients who are unsuitable.
So you prefer to have a neoadjuvant endocrine therapy in a case of a postmenopausal rather than a premenopausal. Am I correct?
Yes, 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 yes.
On the contrary to what the phase 2 trials have shown, that the response rates between premenopausal or irrespective of the menopausal status, some of the trials like NEO-MONARCH and IMPACT trial are shown, and the irrespective of the menopausal status, the response rates are as equally good, whether it's premenopausal, postmenopausal with the CDK4 inhibitor like abemaciclib and all. But it's all phase 2. I'm not saying this is a current standard of care. It's not the there is no proof that the neoadjuvant endocrine therapy is far superior to any kind of and there are, he was talking about, Rajab was talking about the PEP score, that is the prospective endocrine index, which may give you a insight whether the adjuvant chemotherapy can be omitted in a case of HR positive if they are having a good response in a case of a locally advanced breast cancer. So your preference to postmenopausal, I agree with that. That's what an elderly, frail individual, postmenopausal, what will be a choice of what kind of, what is an optimal duration you like to have? After that, you plan for surgery.
When I have to decide between tamoxifen and letrozole, as per the various studies, letrozole is known to have definitely be much better than tamoxifen in terms of disease response. So letrozole would be my drug of choice, and AI, except in those cases, in those patients who are very frail, have severe osteoporosis, who will not do well with letrozole. In such patients, I would consider tamoxifen.
Dr. Prasanna, good evening.
Good evening, sir.
In a case of, as Manjula was talking, still there is no standard of care. What kind of thing, as Manjula was talking, letrozole has got a little higher advantage when compared to tamoxifen, but we have newer drugs like CDK4 inhibitors, we have better drugs, and we have fulvestrant, we have exmestane. So what is the optimal drug you prefer, and what is the optimal duration you like to? As we all know, that 3 to 4 cycles of 3 to 4 months are not going to give an optimal response. What is your take on that?
Okay, so we have to choose our patient according to the favorable subset who responds to neoadjuvant endocrine therapy. So that is more important upfront, because the luminal A tumors with higher ER and PR positivity and a locally advanced breast cancer, probably 70 or 80 plus postmenopausal female, that would be the subset of patients where I would tend to use a neoadjuvant hormonal therapy. So I prefer AI for a duration of at least 4 to 6 months. So probably I will assess the response every 2 months with a clinical examination and also imaging probably in the midway. And at the end of 4 to 6 months, I will complete the clinical examination assessment and also the imaging and assess the response, and then go for the curative surgery.
The response assessment, as Prasanna was talking, Manjula, there wasn't a thought on early dynamic response assessment after 2 weeks with the KI67. Of course, KI67 has to be validated and it has to be standardized. If they have a very well assessed for KI standardized and validated KI67, after 2 to 3 weeks of the early dynamic response of KI67 also being contemplated as one of the markers, biomarkers for response assessment for the ET. And what are the other ways you can assess? Since you are going to be one who is going to operate, you have to assess if somebody has been put on an immunoendocrine therapy with either one of the CDK4 inhibitor or a letrozole. How we are going to assess that patient?
Routinely, I actually assess a patient only clinically, though biomarkers are definitely a useful indicator. We get a biomarker done again. It again takes 3 to 4 days. For me, in a locally advanced breast cancer, technically we can operate. But I always look for disease response. Can I do a breast conservation? Will this help me reduce the nodal burden so that I can get better clearance? Basically, we're looking for margin
But
negativity.
Dr. Manjunath,
So I assess clinically.
Clinical response may have many pitfalls like that, maybe fibrosis, or it may be an ILC subtype with a flat lesion, not a nodular lesion. There are many pitfalls in clinical assessment as well as an ultrasound assessment. There may be variable response in the breast per se as is axillary subset. What the literature says is clinically an ultrasound is not a great response. You need a biomarkers, you need a prognostic index, you need a MRI assessment, you need a genomic signatures for assessing the things. Clinical has got a lot of pitfalls. Fibrosis may be there.
In an ideal scenario, I think all of these that you mentioned, be it an MRI, especially in a lobular cancer, MRI and all these signatures are very useful. But in the Indian scenario, even despite me practicing in a corporate center, we face a lot of difficulty in getting patients to do the initial workup itself, the PET CT, and all of that works out to be very expensive. But even otherwise, when we start a hormonal therapy, neoadjuvant hormonal therapy, my aim is to not make her amenable to surgery in 2 months or 3 months. We give a minimal of 6 months. So I call her every 1 month to 3 months for a clinical examination. Now, what we look for is to see clinically if there is response. Does the nipple areolar thickening resolve? Is there an improvement in the PDO? Does the tumor size, is it coming down? What about the nodal response? The red flag is when for maybe 3 months at a stretch, we don't see any response. We see new nodules. We think clinically the disease is maybe increasing in size or worsening. That would be the time, in my opinion, to go ahead and do imaging, be it a mammogram or an MRI, to do these biomarkers. And at that point in time, even the patient gets alarmed that something is not fitting the picture, and I think we need to look into it.
And if you are going to have a no response scenario, which may be common in a case of like a chart positive hit negative, then you abandon the neoadjuvant strategy and you go for the surgeries, take the patient for abandon the BCS and take up for the mastectomy. Because these are subset of the patients who may have a poor responders.
Yes. So we give 3 to 6 months and we wait for it to respond. Now, in case it's worsening, say in 3 months, it's not amenable and it's worsening, then there is that, even when you give chemo and a disease does not respond, there is that very sacred window where we have to go in and operate. If we lose that opportunity, we lose the chance. So when she's amenable for surgery, if she's not responding to hormonal therapy, then we go in and operate. Though, to be honest, I have yet to come across a hormone receptor positive patient who has not responded to NAHT favorably.
Okay, fine. Any other panelists is there? Dr. Reshma is there? Dr. Satvik is there? Hello? Dr. Roshi, Dr. Reshma and Satvik is there? Okay, fine.
Dr. Satvik has joined, sir.
Dr. Satvik, are you there?
Yes, sir, I'm there.
Fine. your take on a neoadjuvant endocrine therapy in a case of a locally advanced HR positive?
Yeah, so as per the discussion, I agree that most of the time it's the frail patients where we try to give neoadjuvant hormonal therapy because chemotherapy, if they are unfit for chemotherapy. Otherwise, for locally advanced, we try as much as possible to give at least weekly chemotherapy or some form of modified regimens so as to give them the benefit of neoadjuvant chemotherapy in LABC.
But they will not respond. Your HR positive tumors are not going to respond to your neoadjuvant chemotherapy. Response rate are going to be as low as 10%. Okay, fine.
Yeah, but yeah.
It can be as low as 10% in a case of low ER positive tumors. So the neoadjuvant strategy is not going to fail anyhow. Okay, Dr. Prasanna. So you instead of talking about frail patients, the elderly patients, that subset and all, we all know that we don't have other options. But we are talking about young patients, premenopausal. Manjula was talking about premenopausal. Have you ever tried in those kind of patient settings? Still in the US, even the literature talks, and still in the US is less than 3% of the surgeon or the physicians are trying a neoadjuvant endocrine therapy. Even in 2025, less than 3% of the physicians are trying a neoadjuvant endocrine therapy. Have you tried?
I have not yet tried in a premenopausal endocrine positive LABC patient, but we have used a lot in postmenopausal female, even in fit female who are not probably can respond to chemotherapy. We have made patients who responded to neoadjuvant endocrine therapy. We have achieved good responses, but in premenopausal, I have not used.
I actually have something to contribute in this regard. You know, there have been a few studies which have been done on Oncotype DX. Now, Oncotype DX is a genomic signature which is used in early breast cancer, hormone receptor positive, HER2 negative patients. It can also be used in those who are 1 to 3 node positive. Now, when they looked at this in premenopausal women with 1 to 3 node positive, these patients were still found to have high scores and they required chemotherapy. So keeping that in mind, then I think in locally advanced breast cancer, there is no way that you can avoid chemotherapy in premenopausal women. So why not give them NECP first?
Okay, fine. Have you tried a combination of combinatorial approach of a neoadjuvant chemo plus endocrine? People have tried that, but we may have no recommendation for that. People have tried in the case of neoadjuvant chemo plus endocrine therapy in a case of HR positive early breast cancers.
No, I have not used such cocktail, so I don't prefer cocktail in this situation.
People have tried in all those things, and the literature talks about all those things. Okay. With this, the take-home message will be neoadjuvant chemotherapy is now what currently everybody practices, even though the response rates are going to be very low, the conversion rates are going to be very low. In a case of HR positive tumor, still we have so much of apprehension to use a neoadjuvant endocrine therapy in a fit individual, unlike in an older individual. So still we are not, I'm also not using much of neoadjuvant endocrine therapy, but the phase 2 trials are now showing there are conversion rates are improving. PCR rates are low still. Even with the addition of the CDK4 inhibitor, the PCR rates are improved from 10 to 18% only. It has not gone to the level of HER2 positive or a triple negative subset. And we all know that the HR positive tumor is not a homogeneous one, is highly heterogeneous with variable KISS expression, variable ER expression. So these are little needed a lot of biomarkers to identify which is the subset of the patients going to respond to our endocrine therapy, and what kind of endocrine therapy, what kind of duration you need, optimal duration to assess these, and what are the methods by which you assess those things. So it's a long way to go, but still we tend to use more and more. And the another pertinent question is whether who has responded very beautifully to a neoadjuvant care with subset of the patients. Are you going to omit the neoadjuvant chemotherapy or not? Are you going to give the chemotherapy, which may be over treating them? And still the escalation, de-escalation strategy, which are followed in a HER2 positive subset and triple negative subset, are not coming to the HR positive subset. So these are the various questions still have to be answered. So much of unmet needs in HR positive tumors, and even in metastatic, we have unmet needs in HR positive because the recurrence rates are going to be very high in 20, even after 20 years. That's what the literature says. So that's a huge unmet need in the neoadjuvant setting. With this, we conclude this topic and we go to the next topic. The next topic is by Dr. Prasanna. He is going to talk on whether all the postmenopausal women are candidates for extended endocrine therapy or only a subset of the patients do require that. Over to you, Prasanna.
Yeah. Are you able to see my screen?
Yes, yes, yes.
Yeah. So, good evening, everyone. For the outset, I'd like to thank Dr. Rajkumar sir for giving the opportunity, and also the International Association of Integrative Oncology for giving this opportunity. So, the next 15 minutes, we'll be talking on insights on adjuvant endocrine therapy in breast cancer. So, okay. So, approximately 50% of women who get operated will have some form of micrometastasis to be taken care by endocrine therapy in hormone positive breast cancer for at risk of early and also the late distant recurrence. So initial period of time, the response will be achieved, and they can have, after 5 years of endocrine therapy, they can have acquired resistance to endocrine therapy, and they can enter the period of dormancy. So the distant recurrence are also more common in this scenario. And yes, so we know that ER negative tumors are more prone for early relapse, and ER positive tumors are more prone for late relapse. So the risk of recurrence remains the same even after beyond 20 years. So this is what we call it as the carryover effect of 5 years of hormonal therapy, but still the risk of recurrence remains beyond even 20 years. So at least 50% of these recurrences can occur early within 5 years of diagnosis, and the rest of patients can have a late relapse. And the risk of recurrence again remains irrespective of the nodal status. And majority of these invasive disease events are distant recurrences. So we have a long-term risk in spite of the standard of care hormonal therapy for 5 years. We have a long-term risk of a late distant relapse. So, for example, a stage 2 hormone positive endocrine or positive early breast cancer can have up to 30% of recurrences even at 20 years. And in stage 3 tumor, at least 50% of these patients can have recurrences even up to 20 years. So this is again from the meta-analysis of 88 clinical trials of more than 62,000 women and hormone positive early breast cancer. So many patients who are at risk without an effective option to add on to the basic or formulatory endocrine therapy. So we have some clinical, pathological, and genomic determinants for a treatment strategy formulation in breast cancer in young, especially in both premenopausal women and hormone positive breast cancer. Because premenopausal women, we have a different disease biology. So we have to address the fertility preservation. We have to address the germline mutations, especially in BRCA1 and BRCA2, and genomic expression profiling, and also the higher grade and higher stage of the tumor. And also the we have a lot of things to take care of the endocrine sensitivitiness, and we are now having CDK4 inhibitors in adjuvant therapy, and also the adjuvant PARP inhibitors in germline positive tumors. So we have all these clinical, pathological, and
Hello. Roshni? Roshni?
Yes, sir. Yes, sir. Yes, sir.
He has gone offline.
Yes, sir. I guess so. Sir is in a meeting. I guess there is a connectivity issue, sir.
I don't know. Everybody is having connectivity issue except you and me and Manjula. Call him.
A lot.
Hello.
We are trying to connect with Prasanna sir.
Any other panelist is there? Hello.
Dr. Satvik and Dr. Manjula is with us, sir.
Okay. Dr. Sadvik? Dr.
Uh,
Sadvik, are you
Reshma
there?
ma'am. Reshma
Reshma?
ma'am
Yes,
is there.
I'm there.
Sadvik, how your take on extended endocrine therapy for a patient with HR positive?
Yeah, so high risk patients, heavy nodal disease burden, and node positive cases, I would prefer giving extended hormonal therapy.
For
I
how
am
long?
giving extended hormonal therapy to these
How long?
patients.
How long? How long? 10
So
years?
premenopausal tamoxifen for 10 years, postmenopausal letrozole for 7.5 years at
But
least.
they say that after 20 years also you will have the risk is there.
Yeah, but the data as of today is for 10 years, so
So you have
I'll
to
go by
weigh
the data.
between the toxicity versus the
Yeah.
benefit ratio. So
Roshini, can you share my slides, please? Because there is some network problem.
Yes, sir. Yes, sir.
So Prasanna, you will give for 10 years, 8 years. How long you are going to give for high risk?
Yeah. I'll be coming to that, sir. Yeah. I have a few slides on it.
You let us know from which slide.
Can I share? Can I start sharing? Are you able to see the slides?
Yes.
Yeah. So, okay. So this is the prognosis for early breast cancer patients of ER status. We know that it reaches a plateau at 10-year landmark. Both DFS correlates with the OS, and the risk of recurrences even reaches
Screen is visible, sir?
Yeah.
Yeah.
Fine.
Yeah, so it reaches a landmark at 10 years. So we have a 20-year risk of breast cancer after stopping endocrine therapy at 5 years. Again, it depends upon the nodal involvement. So the cumulative risk from 5 years to 20 years in a N0 node patient is 15%, 15%. And when the node is N4 and above, it is nearly 38 to 40%. And again, it correlates with the tumor size. When the patient has a tumor size of at least T2, that is 2 to 3 centimeter, it is 20%. So again, it also correlates with the tumor grade. So the higher tumor grade, the cumulative risk of 5 to 20-year risk of distant relapse is 17%. So again, there is a subset of patients in 3% of our clinical practice. We have a low ER expression. That is 1 to 10% of our patients can have a low ER expression. We usually tend to omit adjuvant endocrine therapy, especially in ER low. But again, it's a grave mistake that what we do. So the omission of adjuvant endocrine therapy even in low ER has worse OS when compared to patients who started on adjuvant endocrine therapy. So even in low ER expression, we also tend to have adjuvant endocrine therapy, which is of beneficial type. So this is the Pan-Asian Adapted ESMO Clinical Practice Guidelines, which is last updated in April 2024. So which says luminal A, we know that adjuvant endocrine therapy is clinically indicated. both in low risk and high risk. High risk, we also add adjuvant chemotherapy, then followed by endocrine therapy. In stage 3, especially in node positive patients, yes, we have adjuvant endocrine therapy. Again, the duration of which extended endocrine therapy, I will come into the future slides. And we also test for germline BRCA1 and BRCA2, and also we have extended use of CDK4 inhibitors, especially abemaciclib and ribociclib with adjuvant endocrine therapy also. So this is again the clear-cut demarcation of premenopausal versus postmenopausal. Premenopausal, you can either go with OFS AI or even tamoxifen in resource-limited settings. In postmenopausal, we have varied options of starting a patient upfront with 2 to 3 years of tamoxifen followed by aromatase inhibitor, or aromatase inhibitor followed by extended aromatase inhibitor, or 5 years of tamoxifen followed by aromatase inhibitor, or even 10 years of tamoxifen. So it is again dependent upon the treatment of physician's choice. So let us discuss different clinical scenarios. One is the stage 1 tumor, which is a T1, luminal A-like, a low grade, that is grade 1 or grade 2. Here, the current recommendation is aromatase inhibitor or tamoxifen, again, when a premenopausal woman with ovarian function suppression up to 5 years. So this is the standard of care. Whereas when you come to the stage 1 or stage 2, especially in a N1 node positive or a MYC patient, then with the luminal A or luminal B, then you can try to extend up to 7.5 years. So here comes the limited period of extended aromatase inhibitor or limited period of extended endocrine therapy. And also you can have an addition of CDK4/6 inhibitors if it fits into the high-risk criteria. And the third clinical scenario is whenever we have a stage 2 or stage 3 patient, the node positive, clinically node positive patients or T4 tumors with luminal A or B, any grade, especially these patients can be pushed for at least 10 years of aromatase inhibitor. And if a patient is a premenopausal, you add with the ovarian function suppression. And also consideration of CDK4/6 adjuvant is also strongly considered along with the extended endocrine therapy. And we all know that the fourth clinical situation, we have a stage 3 tumor, locally advanced breast cancer. So here we have an indication for adjuvant endocrine therapy of up to 10 years and beyond. So this is the current clinical recommendation according to European Society of Medical Oncology. So choosing optimal treatment based on the recurrent risk, again, it's a complex decision. It's not a simple decision to take because we have to balance the safety of the drugs and also the tolerability of the drugs. And what is our ultimate goal is to reduce the risk of recurrence. So we are going from a protection from recurrence and also to the tolerability of the patient or adherence to the drugs. So this is an important question to be addressed. Does all postmenopausal women are candidates for extended endocrine therapy? So again, a pivotal question. Yes, there are trials which showed extended endocrine therapy. This is a snapshot of all those trials in the past, probably 15 to 20 years. Again, the age-old ATLAS and ATOM trials, which studied 5 years of tamoxifen followed by 5 years of, again, extended tamoxifen. Then the studies came up with use of AI after 5 years of tamoxifen, like ABCSG, that is Austrian Breast Cancer Study Group 6 and MA17 trial. And some studies, especially the data study in 2022 published, so it showed extended AI from extended AI of another 5 years probably has a hazard ratio which is beneficial in terms of DFS, but no OS benefit. And the optimal duration of newer AI, probably studied by IDEAL trial and the ABSG 16 trial, again, there is no hazard ratio benefit in overall survey. So what was put together as ASCO clinical practice guideline was with women with a node positive breast cancer should be offered extended aromatase inhibitor for up to 10 years, especially, but when a patient has a low risk node negative tumors, you can restrict up to 5 years. So this is the current clinical practice that what we are practicing today. So let us go into these three trials which addressed limited extended endocrine therapy up to 7.5 years versus a full extended endocrine therapy up to 10 years. We have three trials. One is a data trial, another is the IDEAL trial, and next one is the SALSA trial. So all these, the meta-analysis was tried to compel or compare all these trials So the higher efficacy of full versus extended, limited extended endocrine therapy was in the node positive strata. So the T stage, grade, the patient's age, all, they don't have any significant heterogeneity across the subgroup strata. So this is the tailoring the optimal duration of extended adjuvant endocrine therapy. This is being published in the Breast Journal in 2023. This is a systematic review meta-analysis of these 3 randomized trials. So I will just highlight the important salient points. The data trial showed the limited extended arm of 3 years of anastrozole versus 6 years of anastrozole. Again, the previous endocrine therapy was a tamoxifen. So 5 years of tamoxifen followed by 3 years of anastrozole versus 6 years of anastrozole. Here we have at least 67%, that is 2/3 of these patients are node positive patients. And when it comes to the ideal trial, we have again 2.5 years of letrozole versus 5 years of extended letrozole. The most common endocrine therapy used for 5 years was a tamoxifen alternating with endocrine AI, again with 60% of patients. And here at least more than 70% of patients are node positive patients. Whereas when you come to the SALSA trial, which included more than 3,000 patients, we have node positive patients is just 1/3 of patients. Most of the patients are node negative patients. And again, 2 years of anastrozole compared to the 5 years of anastrozole. So the previous endocrine therapy was tamoxifen in 50%, and again tamoxifen alternating with AI in 42%. So here is a comparison of the meta-analysis. Again, it showed that the hazard ratio for DFS was beneficial for all these trials in terms of limited extended or fully extended endocrine therapy. But this beneficiary is more pronounced, especially in a node positive patients. So in node positive patients, you can have a full extended endocrine therapy according to all these 3 trials, and also these meta-analysis also confirms that these node positive patients are the beneficial patients. So, and in unselected population, there is no significant benefit in early stage endocrine sensitive for a fully extended adjuvant endocrine therapy. But again, due to the powered analysis for node positive patients, you can have a extended endocrine therapy. So longer, probably the carryover effect of adjuvant endocrine treatment, you have a long-term follow-up. So these trials should be fully capsulized for ultimate benefit for prolonged endocrine therapy duration. So we can add even spices to the chai, and now we have CDK4/6 inhibitors in the early breast cancer setting. And again, we have a rationale for combining it with endocrine therapy to take care of the micrometastatic disease. So we know that again, the micrometastatic disease has been taken care better with CDK4/6 inhibitor in high risk endocrine positive early breast cancer. So these are all the trials which showed again the Monarch-E and NATALEE was making a big way, especially in terms of the DDFS, but still the OS is immature, but now the Monarch-E was showing a little bit beneficiary of OS. But the palbociclib with PALAS and Penelope has been negative. And the Monarch-E and the NATALEE has certain differences in terms of 5-year IDFS and 4-year IDFS, and the toxicities of the drugs are completely different. So considering a CDK4/6 inhibitor in adjuvant setting, also in a high-risk patient has to be considered to improve the DFS benefit and also to prevent the late recurrences in hormone receptor positive endocrine therapy. So how do we predict late relapses in a clinical setting? So we know that hormone positive breast cancer has a late recurrence of up to 40%, especially more than 5 years after the primary tumor diagnosis. We have a classical traditional criteria of tumor size, node, and grade. We are all doing it in our clinical practice, and all we have online clinical tools, and also we have a genomic testing. So this is the online clinical tool, that is the clinical treatment score 5. This is the tool which has been developed to predict a late distant recurrence in women diagnosed with ER positive breast cancer who are recurrence free after 5 years of endocrine therapy. And this is from the 2 large clinical trials, the ATTACK trial and Big 198 trial, so which was used to develop CTS5. So we divide into the low risk, intermediate, and high risk. They have less than 5% incident or risk of developing late distance recurrence, that is LDR. In an intermediate risk, we have 5 to 10%, and in late risk, we have more than 10%. So this CTS score is being reflected as a 10-year distant risk recurrence risk score, which is in the visual and text format. So this is what we do in clinical practice. Patients who completed 5 years of endocrine therapy, we divide them into low risk, intermediate, and high risk. In a high risk patient, we need not go for a genomic testing. We directly recommend extended endocrine therapy. So this is clinical CTS score is available online, and for all patients, we can use it in our daily routine clinical practice, which is free of cost. For intermediate clinical risk, we try to offer genomic test, and we know that genomic testing, especially the mama parent non-cotative DX, is going to cost them in lakhs, especially in a resource limited setting. We cannot offer this for every patient walking into our clinic. So only for a select group of patients with intermediate clinical risk, you go for a genomic testing and consider extended endocrine therapy depending upon the risk. And for low genomic risk or low clinical risk, I will not consider extended endocrine therapy. So I will stop endocrine therapy at 5 years. So this is what the practical, free of cost clinical treatment score that is available. So this is again the evidence for it. In postmenopausal women, the low risk, low distant recurrence at 10 years is just 2.9%. There is 3%, whereas the intermediate risk is 7.2%, and in 12.9% is the for high risk patient. So this is the genomic test available. We all know that, but again, it's very difficult to practice in India. The Oncotype DX and Mama Print and even the breast cancer index, we are now being qualified for IDEAL trial and also the MA17 trial. All these tests are being costlier, especially costing more than $1 lakh for the patient. And it's going to be cumbersome for counseling the patient for a genomic testing for every patient who wants to have an extended endocrine therapy which walks into our clinic. So there are some, again, factors. When you try to give a patient of extended endocrine therapy, there are factors for adherence in hormone-positive breast cancer. One is the health system-related factors. Again, the place where you practice, whether you practice in a corporate or a public sector, the socioeconomic factors, and the menopausal status, and other comorbid conditions and prior co-medications also has a say in it. And the tumor size, grade, and lymph node, again, the classical factors, and also the therapy-related factors. The patient is having a radiotherapy and type of endocrine therapy that patient is going to have, on toxicities of the drug. All these things will have an impact on the adherence of the drug when it comes to extended endocrine therapy. So these are all the toxicities of standard versus extended endocrine therapy. So we all know that tamoxifen is a toxic drug when continued beyond 5 years, because tamoxifen has increased risk of endometrial cancer and also hot flushes and weight gain, especially in obese female. Weight gain and mood disturbances are more common, and high chance of deep vein thrombosis and pulmonary embolism, and also the cerebrovascular events are also going to be risk when you try to extend tamoxifen for more than 5 years. And when it comes to the aromatase inhibitors, then you have more of a joint pain and arthralgia, and also the loss of libido, and sexual health is also questionable in a patient. Also, the bone health is also questionable in a patient when you want to try to extend the aromatase inhibitor duration. So it again boils down to your clinical decision and using of online tool of CTS5 when it comes to the extended aromatase inhibitor. So you have to choose wisely the subset of your patients, and also we have to weigh the risk of benefit versus the toxicity of the extended aromatase inhibitor or extended endocrine therapy when it comes to a high risk endocrine positive breast cancer. So thank you for your patient listening.
Thank you, Prasanna, for the wonderful talk on role of extended therapy, endocrine therapy. As we all know that the ATOMS and ATLAS are the landmark trials which have shown that extended 10 years versus 5 years of tamoxifen As we all know that tamoxifen produces a high risk of endometrial cancers, even though incidence are less, but many of the patients will come with endocrine thickness, keep on increasing from 2 millimeter to 3 millimeter and so on, with alarming, touching on the cutoff of 5 millimeter. So how you monitor those things, and anastrozole or letrozole, once again, the bone mineral density, how frequently you monitor if you are planning for extended. These are the two parameters. And of course, we don't have much other than ultrasound estimation. How frequently you do that ultrasound estimations of the endometrial thickness?
So the usage of tamoxifen in my clinical practice is very limited unless the patient has some contraindications or some side effects or intolerance to AI, either a steroidal AI or non-steroidal AI. So the tamoxifen usage is very limited in my clinical practice. So when it comes to AI, the bone health is more important, and upfront DEXA scan has to be done. And I prefer every 6 months of adjuvant bisphosphonate, especially when it comes to the aromatase inhibitor, when a patient has osteopenia or at risk of osteoporosis in an elderly postmenopausal female. So we go with adjuvant zoledronate or probably an ibandronate every 6 months until the completion of 10 years of AI.
The rest of the panelists, what's your take on that? Dr. Satvik and Dr. Reshma, are you there? Dr. Satvik? Reshma?
Yes, sir.
Go
So
ahead, doctor.
I do USG abdomen 6 monthly on patients who are on tamoxifen to monitor the endometrial thickness.
Okay, fine. You practice extended endocrine therapy at least in a high risk subset of the patient?
Yes, sir. In high risk node positive patients, I do counsel them that we'll start. We might have to extend, and depending on the toxicity, if everything is going well, then I'll try to continue for 10 years. Otherwise, I stop early in view of toxicity.
Dr. Reshma, are you there? Okay. Manjula, your take on that?
So when it comes to adjuvant AI, my practice is similar to what Dr. Prasanna practices. When it comes to adjuvant tamoxifen, I routinely do not evaluate the endometrial thickness unless they're symptomatic. If they complain of spotting, then we do get an ultrasound done, and then we look at the endometrial thickness and do whatever is required.
Otherwise, you don't screen
Routinely,
for
no.
endometrial.
Routinely, no.
That's fine.
Unless they're symptomatic.
And bone mineral densities for an anastrozole?
So DEXA scan once a year. And my practice is similar to what Dr. Prasanna does actually, 6
Okay.
monthly.
Still your high risk assessment of an endocrine sensitivity or HR positivity for extended therapy that relies only on the anatomical spread of the tumor, the involvement of the node, or you rely on a genomic profile?
So by genomic profile, do you mean like a genomic assay?
Yeah.
Or do you mean like
you rely only on the nodal
IHC4? No, not nodal positivity, because we have to look at the biology of the tumor, not just the nodal positivity, not just the clinico-pathological factors. We need to look at the biology.
How do you define a high risk subset of HR positive
A
tumors?
high risk would be higher grade, definitely increased number of nodes, a higher Ki67, 4 or more nodes, increased grade, and a higher Ki67.
Okay, fine. Reshma is not there. Dr. Reshma? Okay, fine. Then we close the topic. Nice discussion by all the panelists. We go to the next topic by Dr. Satvik Kadar. This is on HER2 positive breast cancer. Do anthracycline still have a place in the treatment of early stage HER2 positive breast cancer? Dr. Satvik, over to you. Go ahead, doctor.
Yeah, so in very few slides, I would like to discuss the topic: do anthracyclines still have a place in the treatment of early stage HER2 positive breast cancer? So, little bit of history. Anthracyclines, especially in HER2 positive breast cancer, is now essentially history. But let's start in the idea of using anthracyclines started with in as early as 70s, when polychemotherapy was established as an effective way of reducing breast cancer relapses. Then by 90s, the anthracycline taxane based regimens became the gold standard for early breast cancer treatment. Then HER2 came into the picture, and we had HER2 targeted therapies, trastuzumab based therapies, along with anthracyclines, which were being used for treatment of breast cancer. But we know anthracyclines are a difficult drug to handle, both in acute form as well as in chronic form. There are certain risks. We see a lot of bone marrow suppression. We see febrile neutropenias, infections, and hospitalizations whenever we are using anthracyclines. Alopecia is a major concern. Mucositis is very commonly seen in patients who are on anthracyclines. So these are some acute toxicities which we have to face day in and day out whenever we are using anthracyclines in breast cancer and other cancers as well. Then there are long-term risks. We know topoisomerase inhibitors have a secondary AML risk and MDS risk. Although small, but still there is a little bit of risk of secondary malignancies, because these patients, especially our early breast cancer patients, tend to live longer for decades altogether. So this long-term toxicity takes center stage whenever we are following patients for long term. Talking about cardiotoxicity, there are direct cardiotoxic effects which are exacerbated by HER2 blockade. Up to 5% patients develop symptomatic CHF, 20% show sustained decline in ejection fraction after anthracycline exposure, and concurrent administration raises the CHF risk up to 27%. That is why it is strictly contraindicated that we do not give concurrent anthracyclines with trastuzumab. Then along with the HER2, even if it's a sequential therapy, as per the trials, we know that close to 8% patients could not start and 15% patients could not complete trastuzumab after anthracyclines due to cardiac issues. So even if we are giving sequential anthracycline followed by trastuzumab, 15% patients could not complete their trastuzumab treatment, which is a big number. So quickly going through the trials where they have omitted anthracyclines. So this is one of the landmark trials, the APT trial by Toleni et al., where they took early stage breast cancer equal to 3 centimeter node negative HER2 positive patients, and they gave weekly paclitaxel with trastuzumab for 12 weeks, and then trastuzumab maintenance 3 weekly for the rest of the doses to complete 1 year. And for the long-term follow-up of 7-year DFS, you can see it was 93.3%, which was very high despite omission of anthracyclines. And if you see the 10-year results, which were published some 2-3 years back, even after 10 years, the DFS probability was 91%, and RFI probability, where they defined it as invasive local or regional recurrence, distance recurrence, or death from breast cancer, it was 96.3%, which was huge. So basically what this trial established early on also, and it has been in practice since long, that less than 3 centimeter node negative HER2 positive patients need not be exposed to anthracyclines, in a simple short regimen of weekly paclitaxel with trastuzumab for 3 months and then 3 weekly trastuzumab for the rest of the year gives excellent results. Then another landmark trial, BCIRG-006, where again this was an adjuvant trial where node positive patients or high risk node negative patients were randomized into one arm was without AC followed by taxanes, docetaxel. Then a second arm was AC followed by sequential taxane plus trastuzumab. And then it was a non-anthracycline arm of TCH, where they gave 6 cycles of docetaxel with platinum salt, that is carboplatin in AUC 6, along with trastuzumab for 6 cycles, and then maintenance. So again, I would only quote the long-term results. After 10 years of follow-up, only the 10-year DFS rates was 74% and 73% in the TCH versus ACTH arm, and 10-year OS rates being 86% with ACTH and 83.3% with TCH arm, which were the difference was not significant. So what they wanted to highlight that despite omitting anthracyclines in node positive or high risk node negative patients in the adjuvant setting, the efficacy remains same and patients can safely omit the anthracyclines. Talking about the toxicity part in this trial, the grade 3 or 4 congestive heart failure was significantly reduced in the TCH arm. You can see only 4 events versus 21 in the ACTH arm. And if you see the right hand side graph of dip in the LVEF, the nadir as well as the nadir was there was lesser dip in the TCH arm, as well as the recovery was quicker and better as compared to ACTH arm. So basically leading to less interruptions of the treatment and no permanent cardiac cardiotoxicity. So this was about the adjuvant omission of anthracyclines in breast cancer. And talking about the new adjuvant, we have the famous TRAIN 2 trial, where this was when they tried the omission of anthracyclines in the new adjuvant setting. So basically, they again randomized patients into 2 arms. One was paclitaxel carboplatin along with trastuzumab for 9 cycles, and the other was 3 cycles of FEC trastuzumab, then FEC trastuzumab followed by 6 cycles of paclicarbo with trastuzumab pertuzumab. And their primary endpoint was basically PATH-CR, and the efficacy outcomes like RFS OS were secondary outcomes. So talking about the primary endpoint, there was no difference in the pathological complete response rate if the patients, if the anthracyclines were omitted in the neoadjuvant setting in all patients, as well as ERPR negative, as well as ERPR positive along with HER2 positivity. So essentially, the trial met its primary endpoint. It was clearly shown that omitting anthracycline has no difference in the efficacy. If we talk about the toxicity profile, you can see febrile neutropenia was significantly higher, up to the level grade 3 FN was seen in 10% of the patients as compared to only 1% in the non-anthracycline arm. So again, highlighting the fact that it was well tolerated. Talking about the cardiac side effects, you can see there was significant difference in the LVEF decrement of more than 10% or absolute value of less than 50% in the anthracycline arm as compared to the non-anthracycline arm. So again, showing that the non-anthracycline arms was cardiac safer, was otherwise it was a safe toxicity profile was much better with a non-anthracycline regimen. Talking about other secondary endpoints of efficacy, the EFS as well as overall survival curves are well overlapping each other, and there was no difference in EFS or OS, although this was a secondary endpoint in this trial. But the point which they wanted to highlight that ultimate efficacy does not differ with a safer profile. I'll just in brief talk about other new adjuvant trials, the Neosphere, the Trifina, where they again analyzed non-anthracycline arms, and Trifina was basically a cardio safety study, and they showed a PATH-CR rate of 63.6%, which was significant. And these trials basically ruled out anthracycline exposure even in the patients when we are giving new adjuvant therapy to these patients. So it's very safe to say that anthracyclines can be substituted with taxane-based HER2-directed therapy. 2 trials, TRAIN 2 and BCIRG in the adjuvant setting, and we know Trifina and Neosphere in the neoadjuvant setting. The TRAIN, there was less cardiac toxicity, numerically less leukemia, and we know that the standard approach is now TCHP for stage 2-3 HER2 positive disease, and it's very hard to justify someone using anthracyclines in the era of HER2-directed therapies and even the novel therapies, which I have not covered other therapies as the trial was this topic was only early breast cancer. A little bit data for what is the role of TDM1. Can we use TDM1 for stage 1 HER2 positive disease? So there was a trial called ATTEMPT trial where they took stage 1 HER2 positive breast cancer patients with an ejection fraction of more than 50%, and they randomized them into TDM1 versus paclitaxel, so completely non-anthracycline, but still trying to avoid the paclitaxel chemotherapy. The 5-year IDFS and RFI events, there were almost similar in both the arms. Talking about the toxicity, the grade 2 or more neurotoxicity was lesser in TDM1 arm as compared to paclitaxel. So, but there were early discontinuations were more in TDM1 arm. So it was a mixed picture, but still, although not very commonly used, but the trial investigators concluded that it can be used. It can be an alternative to paclitaxel trastuzumab in patients who wish to avoid paclitaxel, maybe because of underlying neuropathy, because TDM1 although has, but the chances of neuropathy are significantly lower. So just to summarize how we treat HER2 positive early breast cancer. So a less than 1 centimeter tumor, node negative, we go for upfront surgery, and based on the pathology, either trastuzumab with taxane weekly, that is the Dana-Farber regimen, followed by trastuzumab maintenance, or TDM1 in very selected cases. In stage 2, stage 3, if it comes out to be stage 2 or stage 3 post-op, then TCHP is the standard. 1 to 2 centimeter node negative, we can go for upfront surgery. If node positive, radiologically, we go for neoadjuvant TCHP, then surgery, and depending on the PET-CR, if it's there, we continue HP. If there is no PET-CR, then we switch to TDM1. And obviously, more than 2 centimeter or node positive, everyone goes for neoadjuvant therapy as of today. So this was all. Thank you.
Thank you, doctor. So your take-home message is that the last slide showing TCHP is a standard of care. So you want to use an anthracycline, or you want to omit anthracycline?
No, TCHP, sir. TCHP, not no anthracycline. TCHP does not have anthracyclines.
Okay, your take is not to use an anthracycline.
Yeah, I'm also not using anthracyclines in all my HER2 positive patients. None of my HER2 positive patients are getting anthracyclines these days.
Okay, what is the reason why you want to avoid anthracycline?
Because we have safer alternatives with equal efficacy. So that's why there's no point. We have seen, as per the trials have also shown, even if we are using sequentially, the treatment interruptions, treatment discontinuations are more, and cardiac toxicity is more, and anthracyclines give a permanent cardiac toxicity, whereas using only HER2 directed agents may have a transient LVEF decline, which is in most of the cases resolves with the interruption.
Okay, doctor. Thank you so much for your nice talk on the role of anthracycline. Now we'll go to the next topic. I invite Dr. Manjula Rao to talk on the accelerated dissection, whether you want to have an accelerated dissection if you have a good responders, subset of the patients who are good responders following neoadjuvant chemotherapy. Over to Dr. Manjula Rao.
Thank you very much, Dr. Rajkumar, first of all, for giving me this opportunity to speak on this platform, and also thanks to IAIO. So my topic sounds, very grand, very big. The topic itself is a sentence. So should patients with heavy axillary nodal disease pre-neoadjuvant chemotherapy, we're stating that they should have an axillary dissection irrespective of the response to neoadjuvant chemotherapy. So how I'm going to tackle this topic today is I'm going to discuss what is the axillary management today? How do we manage the axilla post neoadjuvant chemotherapy, irrespective of the stage? And then let's look at the individual stages. So as we know, axillary management has undergone tremendous changes in the past few decades, with emerging knowledge that routine axillary dissection may add to the survival benefit, with introduction of newer targeted therapies, neoadjuvant therapies, the newer drugs of immunotherapy, and also over the years we have come to understand the biology of breast cancer a little better. Now, the NSABP, the results of the NSABP B32 study way back in the 90s, it established sentinel lymph node biopsy as the gold standard for axillary staging in patients with clinically node negative early breast cancer. Moreover, because there was evidence to show that this helped to decrease the morbidity post-surgery of lymphedema, shoulder stiffness, paresthesias, etc. Now, but post-neoadjuvant chemotherapy, axillary lymph node dissection was always the norm until very recently. And let's look at why that is. Now, why is So why is axillary staging so challenging post neoadjuvant chemotherapy? Now, we know that today, once neoadjuvant chemotherapy is given, data shows us that 40 to 45% of the patients attain pathological complete response. And there is increased usage of neoadjuvant chemotherapy even in early breast cancer, like Dr. Satwik also explained to you in the previous talk. HER2 positive cancers, anything more than 1 centimeter, we give neoadjuvant chemo with targeted therapy and then go forward. Similarly, in triple negative breast cancers. But neoadjuvant chemo has not known to give us improved survival, but it has shown survival benefits if we add additional chemo in those patients who do not achieve pathological complete response. So and neoadjuvant chemo is mainly done as, to avoid axillary lymph node dissection in those with node positive presentation. So how do we do that? Because axillary lymph node dissection, we know that extensive surgery, radical surgery, does not really impact the survival or recurrence rates in patients with node negative disease. So this has raised questions regarding its necessity post-neoadjuvant therapy. Now, what are the issues with sentinel lymph node biopsy once chemotherapy is given? The issues mainly are that the lymphatic drainage gets altered due to treatment-related scarring or fibrosis. So we are not sure about will the dye really reach the node and whether it's really, whether the sentinel node has absorbed the dye or not. The disease response in the axilla might be variable to neoadjuvant chemo. So generally what initial studies have shown us that sentinel lymph node biopsy in the post-NACT setting is associated with poor or lower identification rates of SLNB and higher false negative rates, which is almost 33%, which is very, very high. We are trying to attain a favorable FNR of less than 10%. So where is the safety of this technique, right? And in fact, if a patient has very bulky axillary nodal disease on presentation, like in a locally advanced breast cancer, or say after NACT, the nodes are persistent, this would definitely affect your sentinel lymph node biopsy technique. So axillary dissection was always the norm. Now, let's look at the evidence in clinically node negative patients. So the studies which examine the accuracy of sentinel lymph node biopsy after NACT in patients presenting with node negative disease, they report similar identification and false negative rates as to those in the upfront surgery setting. So there's the NACDP B27 trial by Mamunas et al. They did an unplanned retrospective analysis. And this was in fact one of the first studies to actually report the feasibility of a sentinel lymph node biopsy in the post-neoadjuvant chemotherapy setting. And it supported the practice because of the identification and false negative rates being similar to those if you operate on them upfront. Similarly, with the Gania study that was published in 2009. Now, there's another meta-analysis by VK et al., which included more than 5,000 patients, which supported the feasibility of post-chemo SLNB in those patients who are node negative, because, again, the identification and false negative rates are similar to SLNB done upfront. So the main factors here are we able to identify identify the affected nodes in post-chemo versus pre-chemo? Is it going to be the same? So the ASCO 2014 guidelines, while it did support SLNB in patients who are clinically node negative to begin with, they did not support SLNB in those who are node positive and became node negative after NACT because of inadequate evidence. And again, the false negative rates reached as high as 30%. So while, our main concern is, are we leaving behind lymph nodes with potentially chemo-resistant disease in situ? Right? And the information to address this question is limited because most of these patients most of these studies where, they look at SLNB after NACT, you have to do a completion ALNB to establish the accuracy of the procedure. So then the whole point of the exercise is gone. And there was a paper by the MD Anderson series where, they had around 409 women with negative SLNB following neoadjuvant chemo. They underwent only a sentinel lymph node biopsy. And, after a median follow-up of around 45 months, the regional recurrence rates did not really differ significantly when compared to those with a negative upfront SLNB. So this decrease in the nodal metastasis in patients with node-negative disease undergoing post-chemo axillary staging and the increased rates of pathological complete response in the breast in patients treated with current chemotherapy regimens, this actually improved the study of SLNB amongst patients presenting with node-positive disease. I'm sorry, I'm not sure what happened. So now let's look at whether performing a sentinel lymph node biopsy in patients who are node positive to begin with and become node negative after NACT, is it feasible? So we have 4 landmark trials. These are prospective multi-institutional trials which looked at this. You have the ACOSOC Z1071, FNAC, Sentina study, and the Gania-2 study. And if you see in this study, the identification rates were all comparable, and the false negative rates all range from 11 to say 15%. This was still high because what we are looking at is getting an FNR of less than 10%. But while it looked like SLNB was feasible in such patients, there was still something that was missing. And then further look at the data showed us that the use of a dual tracer, that is if you use 2 dyes to perform the technique, and if you at least remove more than or equal to 3 sentinel lymph nodes, this brought down the false negative rates to less than 10%. But all these studies only looked at patients with node positive disease becoming node negative. In those with some of these studies which looked at N2 disease becoming node negative, the results were not really favorable. So currently, we can think of performing a sentinel lymph node biopsy in those patients with limited axillary nodal burden positivity pre-NACT who become N0 after chemo. In case they remain node positive after chemo, then axillary lymph node dissection is the norm. So while we are discussing the false negative rates, it's important to see how do we improve the FNR in post-chemo SLNB. So of course, using a dual tracer, dual dye technique is the gold standard. We must ensure a higher nodal yield of at least three or equivalent lymph nodes. Now, the question often asked is, many of these patients, they respond very well to chemotherapy. And what if you're not able to find, 3 sentinel lymph nodes? Well, the answer in this case is, we look at some of the other factors that you need to look at. But if you're not satisfied with your nodal yield, then it's better to do an axillary sampling, a level 1 dissection, or a complete ALNB, because we do not compromise on oncological outcomes. The other technique to improve the false negative rate is something called TAD, or targeted axillary dissection. So in this, what is done is the positive node pre-chemo. So it can be 1 to 3 positive nodes. These nodes are clipped or they are marked. After chemo is given, just before surgery, a wire or something is placed to localize this node. And in India, currently we use only a wire to localize. So just like you localize the disease in the breast with a wire, you do the same thing for the axillary node as well. And then at the time of surgery, when you do sentinel lymph node biopsy, you ensure that apart from the sentinel lymph nodes, you also take out this wired node. And the studies that have looked at the combination of sentinel lymph node biopsy and TAD, they report that this clipped lymph node is not a sentinel lymph node in 10 to 25% of the cases. So combining the SLNB with TAD further reduces the FNR. But the caveat is that all these studies which looked at it, they all had different techniques of sentinel lymph node identification. And they all, they had different numbers of sentinel lymph node excised. So the exact benefit of TAD, what is the additional benefit it actually offers apart from using a dual dye or your nodal yield is not really known. So what we recommend is that in setups where you can, where TAD is feasible logistically and it's not going to, be a hassle to the patient, please do perform a TAD. But otherwise, you can still perform post-chemo SLNB by using the dual dye technique and ensuring an optimal nodal yield. Now, why are we always harping on a false negative rate of, less than 10%? Because in primary surgical setting, in node negative patients, upfront surgery, this is associated with a low axillary failure of less than 1%, and that's why. So these are, from all the slides that we've looked at and what we've discussed, for if one needs to do a post-chemo SLNB, one needs to use a dual tracer method, take out at least 3 axillary lymph nodes, you can consider a targeted axillary dissection. But one needs to keep in mind that when considering de-escalation in oncology, be it breast conservation, be it sentinel lymph node biopsy post-chemo, it's very essential to select the patient appropriately. And what do we mean by this? So it's not that just because, I want to say that, yes, I do post-chemo, I do a sentinel lymph node biopsy, I'm going to give chemo, this patient appears to be node negative, I'm going to go ahead with it. No. So there are certain factors that we need to look at. So this is a very nice paper by Anna Weiss et al., wherein they enrolled patients, who were included in the CALGB 40601 and 40603 study. So there are around 759 patients. And when they looked at this data, it showed that the rate of nodal pathological complete response depended on the tumor size, a lower clinical T stage, they performed better, and they were more likely to be node negative at the baseline. And especially those patients who had nodal PCR, the most important is that they were more likely to have experienced a breast pathological complete response as well. So when we are, considering or selecting the patient, we need to evaluate the biology. We need to see, has the disease in the breast responded equivalently? What is the biology of the disease? What is the Ki-67? Can we go ahead? So that is how our thought process should be. And now compared, and in this paper again, it was seen that compared with patients who had residual disease in the breast post NACT, those with pathological complete response, they were 12 times more likely to have achieved PCR in the nodes as well. The overall survival was significantly worse amongst those patients with residual disease in the breast and node positive disease post chemo than those with breast or nodal PCR. So in selected patients, smaller tumors, node negative disease pre-NACT, or in axilla with positive node but a low axillary nodal burden, we'll evaluate the disease biology and we can consider de-escalation of axillary surgery based on the response of the breast disease to chemotherapy. It is very important to accurately assess the residual disease in the axilla and breast post NACT. So for this, in the clinic, we rely on imaging, so be it mammogram, ultrasound, in order to corroborate the results. And appropriate protocol mediated systemic treatment has to be administered. So patient selection and technique is key. So sentinel lymph node biopsy is definitely less reliable in the post-NACT setting, but we have studies now which have helped us identify means of reducing the inaccuracy, reducing the false negative rates, and improving the identification rates as discussed. So this technique, SLNB, is very well accepted in those patients who are clinically node negative to begin with and receive chemo. In those who are node positive, low axillary nodal burden, who become node negative, it is important to select the patients appropriately based on the biology and the disease response. But currently, when you look at all the studies that we have, there is no evidence for sentinel lymph node biopsy post chemo in those with a heavy nodal burden or N2 disease and beyond. So in such patients, those who have an internal mammary lymph node, a supraclavicular lymph node, matted axillary lymph nodal burden, today axillary clearance or axillary lymph node dissection is key. So of course, there's still, scientific studies and efforts are ongoing to identify optimal strategies for axillary nodal staging in breast cancer. What we need to remember at the end of every discussion with regard to oncology is that biology is the king. Case selection is the queen. And the technical details of the surgical procedure come only much after that. So thank you very much for the opportunity and thank you for your patient hearing.
Thank you, ma'am.
Am I audible? Yeah. I'm just wondering if I'm audible.
Yeah,
because
you're
there's
audible.
no
Yes,
response.
of course you're audible, ma'am. Yeah, thank you so much. Thank you for the very wonderful talk, ma'am.
Thank you.
Sorry, I was muted. Sorry. After a wonderful talk, sorry for that. After a wonderful talk, listening to you, I will dissect your talk and I try to have a clinical perspective. What is the rate of lymphedema in Indian context? We all know the Western is, what is the rate of lymphedema following dissection of the axilla? In Indian context, Western they say is 13%, but we have higher amount of lymphedema because of the extensive lymphatic dissections. What is the rate of clinically? What is the rate of?
So in publications, the documented rate of lymphedema post ALMD varies from anywhere between 20 to even as high as 75%. And this includes literature from the past. Now, in current times, the rates of lymphedema after ALND is supposed to be anywhere between 25 to 40%. Though, to be honest, when we discuss this, if we don't look at the papers and we discuss this in conferences, people will tell you that it's a lot less. But then we still, I think, need to cumulatively look at our data because, even grade 1 lymphedema, it doesn't need to be huge limbs and, where it looks, even grade 1 lymphedema is a problem. So definitely, and it's not just axillary lymph node dissection, it's also the radiotherapy, which we need to give in the adjuvant setting, which adds to that.
Okay, this is very high in context. I agree with you. That's what many of the surgical oncologists, many of the forums denied that that the rate of actually the lymphedema is less. Number two, what kind of technique you follow in clinical practice to assess the SLN?
So you mean post NACT or?
No, generally. We will go with the stepwise fashion from the basic to the.
So pre-operatively in any patient that walks in, along with the mammogram, we do an ultrasound for corroboration findings. And when we do the ultrasound, apart from my clinical examination, I ask the radiologist to tell me which are the suspicious nodes and how many nodes look suspicious. And if it looks like, there's a loss of fatty hilum, cortical thickening, or any one of these factors where it looks suspicious, we get an FNAC, or when possible, I insist on a core needle biopsy of the axillary node to correctly assess whether it's node negative or node positive. If it's node negative, fine. I also correlate these findings with the uptake on the PET CT. If it's node positive, then I ask my radiologist to let me know how many nodes, whether 1, 2, 3, or much more. Apart from that, if they tell me there is a single level 2 node, then I actually don't consider post-chemo SLNB, because if you look at our traditional learning, when we do axillary dissection, we have to go one level higher than whichever node was positive. So if it's level 2, then you go to level 3. If it's level 1 nodes are positive, you go up to level 2 dissection. So only if it's level 1 nodes, 1 to 3 limited nodal burden, do I consider sentinel lymph node biopsy. My method to evaluate the nodal status remains the same, even post-chemo. It is a combination of clinical and clinico-radiological examination. And do you want me to talk about the sentinel lymph node biopsy technique on table?
Yeah, yeah, on table, what you practice.
So on table, now when I initially started out, I always use a dual dye technique. So methylene blue is easily available, and I used to use Technetium 99 because we didn't have the camera for ICG. Now Technetium 99, there are challenges because it's radioactive material. You have to move the patient to a nuclear medicine facility, get the dye injected, get them back. It has to be timed, so if the lab opens and they have the dye only in the morning, say 9 o'clock or 8 o'clock, then you can time your surgery only after that by the time patient comes back. So it was quite cumbersome, but we did that for quite some time. And then I was lucky enough to get hold of the ICG camera. So then instead, for some time, along with the dual dye technique, I used the indocyanine green also to look at the feasibility and all of that. And then, of course, we have enough evidence today for ICG. In fact, they say that ICG can be used as a single dye technique as well. So currently, I use a dual dye technique using methylene blue and ICG to perform sentinel lymph node biopsy.
And the response for your neoadjuvant strategy is keep on pushing the boundaries from 40% to 60%, especially in triple negative HER2 subset with the dual strategy anti-HER2, with your ADCs, with your immunotherapy in triple negative. The percentage of responses in the axilla as well as the breast are keep going up to 60% now. So now, if you are happy to have a patient who has got responded very beautifully to a neoadjuvant strategy, the HER2 subset or a triple negative, it's after your talk, if there is going to be no node at all, complete disappearance, you would still want to go ahead and do a accelerated dissection.
In the light of current evidence, yes, I will not, patients who are, even if they have had fantastic response, if they were node positive or even node positive to begin with, especially, I would still not negate axillary nodal staging. That concept of negating SLNB has come in currently only in early breast cancers. You have the SOUND trial and a couple of others. But that also, the criteria that they have looked at is very small tumors less than 2 centimeters, luminal A disease, very low grades. How often do we see such patients, usually such patients, we end up going ahead with upfront surgery. So anything which is
a node positive, if you're going to be a node positive upfront, you are going to do the accelerated dissection. Am I correct? In the post-neoadjuvant setting. If going to be a node positive.
If it's node positive, if it's 1 to 3 nodes and it's become node negative, then I will do a sentinel lymph node biopsy. If that sentinel lymph node biopsy shows me a positive node, then 100% is going to be an axillary clearance in a post-NACT setting.
So if you're going to planning for an axillary dissection, you're going to do an extensive one, you are going to limited one. Now we have the TAD as an option. So you're going to confine only to TAD. You're going to remove only adjoining 2 more nodes along with your sentinel node, or what is your take?
I don't do TAD because I find it very cumbersome. I have to wait for the radiologist, get the wire placed and all of that. And, so I actually do my wire localization for the breast 1 day prior. So then imagine having wires coming out of the axilla as well. So I don't find that technique very feasible for my practice. But there are definitely ways to do it. That's because we use wire. But if we have the ferrous ion particles, the magnetic technique which comes, I'm sure we can do that. There are, of course, other practical things to consider in terms of costs, logistics, all of that. So I don't do that. I use a dual dye technique and ensure that I at least remove 3 to 4 sentinel lymph nodes. There was there were 1 or 2 cases where in the last 6-7 years where I was not able to find a single sentinel lymph node. In such patients, I did a complete axillary lymph node dissection. And one of these patients was actually T4B disease. She was a 75-year-old lady with a tumor in the inframammary crease. So in such patients, in the inframammary crease, the skin will definitely be involved. It becomes T4B. So automatically, there will be, in such patients, it's not advisable to, I should have actually gone straight ahead with an axillary clearance.
So you come
Because it was
across
locally advanced.
without any SLNB also. Patients will not, the traces will not be taken up and no SLNB will be shown at all.
Yes, it's possible. It's possible. And in such cases, then one must go ahead with a complete axillary lymph node dissection.
Fine. So that was nice. For want of time, we'll move to the next topic. Thank you so much for the
Thank you. Thank you so much.
We will go to the next topic, the triple negative breast cancer. Dr. Reshma is there? The role of immunotherapy in triple negative breast cancer. Dr. Reshma?
I'm there. Slide presentation. Sharing of my slides.
Yeah. Dr. Manjula is there? Dr. Manjula? Roshni?
Hello, can anyone help me with?
Ma'am, is it Dr. Reshma, ma'am? Is it okay if we are
Yes,
sharing
yes.
the slides from our end?
Yes.
Yeah, just give me a moment, ma'am. I'm sharing the
Yes.
slides.
Okay.
Dr. Reshma, go ahead.
Yes, I can see it. Yes, I can see the slides. Very good evening, everyone. And I'll be discussing a very interesting topic, role of immunotherapy in triple negative breast cancer. And we'll be seeing its role both in the early breast cancer as well as metastatic breast cancer setting. So next slide, please.
Reshma, sorry to interrupt you. Are you on video? Can you come? Is possible to be on video so that we have a good interaction? Okay, anyhow, go ahead. Okay, no problem. Go ahead. No problem. Go ahead, doctor. Dr. Manjula, there is a question on the chat box. Procedure of SLNB with dual dye technique.
Yes, I see that.
She joins, she got disconnected.
Yes, sir. I'm there, sir.
Okay,
I was in a little poor range, so I can start now, sir. I can start.
Yeah, fine.
Okay.
Go ahead.
Okay. So, with the want of time, not going much in detail, so a small overview of the triple negative breast cancer. Next slide. So basically, triple negative, it is approximately, it accounts for around 20% of our cases of our clinical practice. I'm sure everyone will agree. And basically, they are considered aggressive. They happen more in younger age group patients. And even though they sometimes present to us in the early stage, there is still quite a high chance that later on they may metastasize. So next slide. So, coming to the classification of triple negative, I think this is a very important slide because the classification of this molecular type classification of triple negative does matter in our treatment decisions. So, basal-like 1, basal-like 2, luminar androgen receptor type, mesenchymal stem cell, and immunomodulatory. So, these are the molecular subtypes of triple negative, very important molecular wise because they also differ in the treatment decisions. So, the immunomodulatory subtype, it is the one which has high TIL infiltration, high CTLA4, PDL1 expression. And so there is a very high chance of them responding to immunotherapy. So as compared to our hormone positive or our HER2 positive subset, we always know that the triple negative generally responds very well to immunotherapy. The main reason being all of these factors. Next slide. So now coming to the, I'll be discussing two important trials. One will be in the early triple negative breast cancer and one will be in the advanced metastatic breast cancer. So in early triple negative, we all know now that Keytruda in combination with chemotherapy as a neoadjuvant treatment and then continued as monotherapy as adjuvant treatment after surgery is indicated for the treatments of adults with locally advanced or early stage triple negative at high risk of recurrence, that is specifically stage 2 and stage 3. Next slide. So we'll be discussing the key trial, which led to the approval of Keytruda basically in early triple negative breast cancer. Next slide. So the Keynote 522 trial. Next slide. So in this Keynote 522 trial, the basic inclusion criteria were those patients of stage 2 and stage 3 deemed to be at high risk of recurrence post therapy. So these patients are mainly included. So the key inclusion criteria were like tumor size, if it is between 1 to 2, but if it is node positive, and if it is tumor size more than 2, then any of the, irrespective of the node, you can include. The inclusion were irrespective of the PDL1. So that is very important point which I want to highlight. And when this schedule was, when Keytruda was added, we also had to include carboplatin in our NACT regimen. So it was Keytruda along with Paclitaxel. Then Keytruda was continued along with the AC or EC regimen, that is of the physician choice. Then after the surgery, Keytruda was continued as a monotherapy for the next 9 cycles. The key endpoints, of course, being the pathological CR rate, the EFS, and then ultimately the OS. Next slide. So this is the schedule which I just talked about. We usually use the Paclitaxel every 3 weekly, followed by AC regimen every 3 weekly. And the Keytruda was also included every 3 weeks along with this. And in certain situations, even a weekly regimen was also allowed. And then in the adjuvant setting, Keytruda was continued 200 mg every 3 weeks for the next 9 cycles. Next slide. Certain baseline characteristics like the age would not want to go, and because of the want of time. So we had patients, I think important that we had patients of N0 49%, N1, N2 40 and 11%. So I think that is, and the overall disease was 75% was stage 2 and 25% was stage 3. Next slide. And most of them having a good ECOG performance status. So now correlation of PathCR with OS. So whenever there is a meta-analysis, whenever we have a meta-analysis, that we have found that this is a meta-analysis of 52 studies globally. So whenever we have done this analysis as compared to the patients who had PathCR as compared to those who have PathCR have a significantly better OS. So this has been a meta-analysis which has proved that this is the association of PathCR and OS. And I'm sure in the real world, in our clinical practice also, we find patients who have had PathCR doing very well as compared to those who have not. Next slide. So correlation of PathCR and EFS also. So in triple negative, the 5-year EFS of patients with PathCR was 90%, and those without PathCR was 57%. So this is also a clear separation of graphs with showing the relationship of PathCR and the event-free survival. Next slide. So these two slides are basically, we are just trying to show correlation between PathCR and a very good overall survival and a good EFS rate. So PathCR as an endpoint for triple negative. So that is why this is one of the important endpoints that this trial has chosen, because it correlates very well with the EFS and OS as per these graphs also. So patients who have achieved a PathCR have a longer EFS and OS than the patients who have not achieved a PathCR. Next slide. So PATCR rate in the ITT population. So in this trial, in the keynote, coming back to the keynote 522 trial, so the PATCR rate, so 13.6 more patients had a PATCR with Keytruda chemotherapy versus placebo, and the PATCR was 64% as compared with 51% with placebo. So we can see that the PATCR when Keytruda was included improved by more than 13 to 14%. So it was 64 versus 51% in the Keytruda arm as compared to placebo. Next slide. So by the nodal status, so now the PATCR, if you see, if you had a node negative patient versus a node positive patient, so even in these both, still the PATCR was 64 versus 58 and 64 versus 44%. So even in a irrespective of the nodal status, the PATCR rates improved by the addition of Keytruda. Next slide. And first EFS analysis at the first IA2 also, EFS in the Keytruda group was 91% versus 55% in the placebo group. So this was a clear advantage of EFS in the Keytruda arm also. Next slide. This was at the analysis which was done at 18 months. And in the entire ETT population, so number of patients with an event was 16% with Keytruda chemotherapy, 24% with placebo. Neoadjuvant treatment with Keytruda chemotherapy followed by adjuvant was associated with a 37% reduction in the risk of an event. So even in the entire ETT population, we could see that there was a clear-cut EFS benefit at our analysis, which was approximately around 3 years. Next slide. So there is a clear separation of graphs as we proceed further in the timeline. So EFS by PATCR. So patients with PATCR, the PATCR predictive of better outcome with or without Keytruda. Higher PATCR rates are associated with Keytruda. EFS with PCR after pembrolizumab better than in patients with PATCR without pembrolizumab. So EFS by PATCR, whenever those patients had a PATCR, the EFS was way much more better than those who did not have. So it was 94 versus 67%. Next slide. We are discussing keynote 522 more in detail because the other trials, which were done with the other immunotherapy, which I'll just show in a slide format, did not really have any OS or EFS benefit or did not translate. The PATCR did not translate into that. So that is why we are discussing more the keynote 522 data because that is the one which has been approved by the ISMO and NCCN guidelines. So as far as the safety data is concerned, even in those patients who were receiving Keytruda as compared to the placebo, there was just a slight addition in the rate of rash or diarrhea, and otherwise no specific adverse grade 3 events which led to discontinuation, etc., or which affected the therapy or the quality of life or the surgical outcomes. Nothing of that sort was observed. There was just a minor increase in grade 1, grade 2 events like diarrhea, rash. So we continue the neoadjuvant treatment safely. Next slide. So again, by subgroups also overall in each and every subgroup, irrespective of nodal status, the tumor size, the PD-L1 status, age or ECOG performance or the carboplatin schedule, irrespective of everything, every subgroup did show an EFS advantage in combination with Keytruda. So it was a significant benefit as compared to placebo. Next slide. So now coming to the summary of this trial, so patients had an EFS event in the Keytruda 16% as compared to 24% in placebo. 87% EFS as 24 months versus 87.8 in the Keytruda chemotherapy group versus 81% in the placebo. Estimated EFS as 36 months was 84% versus 76, and 64% had a PATCR with Keytruda versus 51. So 64% PATCR, I think, is a very clinically significant rate. That is, 64% of your patients are achieving a PATCR, which is going to translate into an excellent EFS and OS later on in their life, where we know that these triple negative subtypes are really aggressive subtype of our breast cancer patients that we are treating in the clinical practice. So next slide. So I'll just wrap up the discussion of early stage so that we can discuss the advanced stage. So in the ISMO, again, this trial which was presented, the overall survival results of this keynote 522 study. Next slide. And they showed that in this recent update in this ISMO presentation also, the updated EFR event-free survival being 81 versus 72% at the end of 60 months with a significant HR value. Next slide. So these are just an updated end points of this trial. And as far as the OS is considered, the separation of curves continues even at 60 months. We are having a 5-year rate of 86 versus 81%. Next slide, with a significant HR value. So again, continuing, the overall survival benefit is consistent across all the patient subgroups. Next slide. So treatment-related adverse events, no significant grade 3 adverse events that led to any discontinuation or affected the surgical outcomes. Next slide. Next slide. So summary and conclusions. So this neoadjuvant pembro with chemo followed by adjuvant pembro, statistically significant, clinically meaningful improvement in the OS and EFS. So it has been included in the NCCN guidelines. So neoadjuvant Keytruda and chemo followed by adjuvant continues to show a clinically meaningful improvement in EFS compared with neoadjuvant chemo after a follow-up of over 6 years. And with longer follow-up, the toxicity profile remained consistent. There was no new additional safety signals to be noted in this 6-year follow-up, and the results provide further support for neoadjuvant pembro plus platinum containing chemo followed by adjuvant chemo as a standard of care for treatment regimen for patients with high risk early stage TNBC. Next slide. So for the want of time, I am a little rushing through the slides. So the PDL1 testing does not define you can include your patient irrespective of the PDL expression level, because the benefit is consistent across all the PDL1 levels. Even though, as we all know, that as the PDL1 expression increases, the benefit increases even more. Next slide. Adding PET Keytruda to neoadjuvant does not add to the complications, and neither does it delay the surgery. So it would not interfere with your surgical outcomes. Next slide. So this is just one table in which we have tested other checkpoint inhibitors also, like the IMPassion trial, atezolizumab, then we have the NeoTrip trial, then we have the durvalumab trial. So every trials were done with the other molecules also in the neoadjuvant setting, but unfortunately none of these trials could actually translate into a PATH-CR or an EFS benefit. So we, as of now, do not have approvals for any other checkpoint inhibitors, even though the trials are ongoing for some agents. Next slide. So now NCCN recommendations we have already discussed. So addition of pre-op Keytruda to these regimens followed by adjuvant Keytruda for the next 9 cycles. Next slide. And all stage 2 and stage 3 TNBC will be advised Keytruda in the neoadjuvant setting. So now coming to the next important trial discussion, that is the advanced TNBC. So the role of immunotherapy in advanced TNBC. So next slide. I'll start with the NCCN discussion. So once you open your NCCN guidelines, what we see is that in the first line, whenever you have a patient whose CPS score is good, like, it is more than 10 PDL1 positive, you are supposed to include or add or suggest your patient addition of Keytruda along with chemotherapy as a category 1 indication, along with either a paclitaxel background or a gem-carbo backbone. So this is the first line indication. If your patient is PDL1 positive with a CPS good score, and in case your patient is PDL1 positive with a CPS less than 10, the only indication is systemic chemotherapy. And in PDL1 negative patients, the addition of immunotherapy is not proven to be beneficial. In the metastatic setting, this is different as compared to the neoadjuvant that we just discussed. So coming next slide. So we'll be discussing the important trial which led to the approval of this Keytruda molecule in the metastatic setting. So again, I've already discussed the types like basal, luminal, mesenchymal type, and the immunomodulatory, which has a very high and very good response rate to immune checkpoint inhibitors because of the certain pathophysiology or the histology and the good presentation of immune cells in the tissue immunomodulatory subtype. Next slide. So one point which I want to highlight at this point is, of course, that we all of us, whenever metastatic TNBC patients come to us, we do advise them an NGS, and we would also want to advise them a PD-L1 testing when they come to us for the first time. These are the chemo backbones, so taxane, platinum, capecitabine, paclitaxel. So all of these, they have had an objective response rate up to 30-50%, but then the PFS is not very great. So we would always, next slide, have an unmet need where we would want to have another agent to improve the outcomes of our patients. So that is where the role of immunotherapy, next slide, that is why the role of immunotherapy came. And this the trial which we are going to discuss gave us the benefit of adding Keytruda to the chemotherapy backbone. So there was always an unmet need. Patients continued to relapse, had a short PFS. Chemotherapies are associated with a lot of side effects, and the quality of life was not very good when you move from one chemo to another chemo. So there was a unmet need of an agent with the lesser side effects, which we could add on to chemo and then continue it as a maintenance. So next slide. So NCCN guidelines recommend Keytruda plus chemotherapy, the backbone being Pacli or a Nab-Pacli or a Gem Carbo, category 1 and the first line settings for patients with PD-L1 more than CPS, regardless of the germline BRCA mutation status. So this is the NCCN guideline. Next slide. So PD-L1 testing, next slide. Again, there was a short time for me for this talk. So details about the PD-L1 testing would not be discussed. Next slide. But I would insist that this trial included the test type, which is called as PharmaDx22C3. And this is how the slides, CPS less than 10, more than 10, they actually look like. So we are interested in a CPS score, which is more than 10 in a PD-L1 positive by the assay, which is specifically 22C3 PharmaDx. Next slide. Because this was the assay which was standardized, and this was the assay which was used in this, and I'm sure in our clinical practice also all of us are using this assay. So coming to the next slide, coming to the indication and the discussion of this trial, keynote. Next slide. 355 trial. Next slide. Inoperable cases aged more than 18, confirmed TNBC cases, and more than one measurable disease. And one important point, that these were de novo patients or in whom the adjuvant treatment was taken more than 6 months back. And exclusion criteria were the ones who had already received immunotherapy. Next slide. So the again important endpoints being an overall survival, the objective response rate, EFS, PFS. So these were the important primary endpoints, and the secondary endpoints also being duration, disease control rate, etc. So they were randomized 2:1 into Keytruda along with chemo versus placebo, and the chemo could be Pacli, Nab-Pacli, or a Gem Carbo background, and then it could be the Keytruda could be continued post completion of the chemo cycles. Next slide. Now let us discuss the results of this Keynote 355 trial. So this is the schedule. You could use a weekly schedule or a 3-weekly schedule or a Carbogem background. Next slide. And the recommended dose being 200 mg 3 weekly or 400 in every 6 weeks. Next slide. This is the way CPS is calculated. Next slide. So there were total 847 patients. The 53 was, the median range, the ECOG performance status being very good, most of them having 0 performance status, and the tumor PD-L1 expression, 38% of them had CPS more than 10. Next slide. These were the baseline patient characteristics. Now, some of the patients received Nab-Pacli 100 mg per meter square IV weekly. Some received Pacli 90 mg per meter square weekly. And rest of them have received Gemcitabine Carbo as per we give it in our standard clinical practice, 1000 mg per meter square, and 2 AUC, Carbo AUC as per AUC2. Next slide. So in the keynote, the PFS data for those patients with a PD-L1 more CPS more than 10, again what we can see is a clear separation of graphs. The PFS being 9.7 in the Keytruda versus 5.6, and the number of patients with an event was 136 versus 79. So again a clear benefit of adding. So 35% reduction in the risk of disease progression or death with Keytruda in combination with chemotherapy. Next slide. and this was at per a median follow-up of approximately more than 2 years. Now those tumors OS data, so OS was again very good separation of grafts which continued to have consistent benefit across time. So 27% reduction in the risk of death in combination with chemo as compared to the one with placebo arm. So median OS was 23 in the Keytruda arm versus 16 months, and 24-month OS was 48 versus 34 months. So next slide. So again with the CPS more than 10, you can see a clear benefit in the PFS and OS. Again, the benefit was consistent across all subgroups of age, geographical status, ECOG performance, the neoadjuvant, irrespective of the neoadjuvant, adjuvant chemo, or the number of metastatic sites. So it was benefit was consistent across all the subgroups. Next slide. The response rates, if you see, the objective response rate was 53 versus 40% in the Keytruda arm. The median duration of response being 19 versus 7.3 months. So again, in this end point of ORR, also the benefit in the with the addition of immunotherapy was very obvious with a CPS more than 10. Next slide. The median duration of response was also very good in this. So the disease control rate of 65 versus 54 months, and the stable disease was 24 versus 44 months. So good disease control rate, a good ORR, good PFS and OS in those patients with a CPS more than 10. Next slide. So selected safety data, again, I have highlighted in the last keynote trial as well as this, nothing particular, no safety signals, but like we all know, we have some turn rashes, some reactions, loose motions, colitis, some derangements in our thyroid function here and there. So these are the things which we observe in our clinical practice, but up till now, I've never had, any reason to not give Keytruda because of any side effects. So generally the safety data were consistent with the other keynote trials that all we have seen in other indications also. Next slide. So summarizing this keynote 355, so the OS median in months was 23 versus 16 months. The PFS was 9.7 versus 5.6 months in the Keytruda versus placebo arm. Next slide. The objective response rate, the disease control rate, the objective response rate was again, we had a good number of 17% who achieved a CR versus 13%. The disease control rate was 65 versus 54, and duration of response was 19 versus 7 months. Next slide. So next slide, the subgroup analysis again consistent. Now this is an important slide which I wanted to highlight. So even in those patients, where a CPS was more than 1, in clinical practice, there would not be every time that you would get a very good CPS more than 10. So even if you have a CPS more than 1, you could still advise it, because the CPS score, this more than 1, this graph, you can see that there is still a separation of graphs where you can get a PFS of 7 versus 5.6 months in a PDL1 score CPS more than 1. So even if you have a PDL1 positive patient, you would not be wrong even if you would want to advise Keytruda to your patient. And the ITT population, 18% reduction in the risk of death. So this just highlights that even in a CPS more than 10, the data is still favoring the Keytruda. Next slide. However, in the PDL1, negative or, in this table, if the PDL1 is less than 1, the PFS, is 6 versus 6. So if it is a PDL1 negative patient, maybe we would not want to advise Keytruda to them, because even in this trial, 25% were patients included had a CPS less than 1. But if you have a PDL1 negative CPS negative patient, you would not be able to give any benefit to your patient as compared to the cost of this molecule. So we would want to advise this molecule only if the patient is PDL1 positive, CPS score more than 1. Next slide. So this was the discussion about role of immunotherapy in early stage and metastatic. And in metastatic, also other molecules have been tried. We all know that atezoli ABCP regimen, atezoli bev paclitaxel, was also once approved in metastatic TNBC, but later on the approval was withdrawn because the benefits of the long-term updated analysis of that trial did not show a consistent benefit. So atezoli, they have tried avelumab, they have tried durvalumab, but these have not really shown any good results up till now. But I can tell you that few of the molecules are still in trial. So we may have certain molecules coming up in the near future. So like we all know, the newer Chinese molecules, Chinese immunotherapy data is also now coming up. We have toripalimab, etc. So we've had this data, but they are as of now not in the guidelines. But we have had other countries that have started using other molecules like toripalimab, etc. So we would soon be having that data also. Like we would want some Indian data, some Asian data, and real world evidence of benefit of torimalimab and other Chinese molecules. So thank you so much, sir, for inviting me to give this talk today. And it was a very good opportunity to interact with you all.
Thank you, Dr. Reshma. We have overshoot the time by about 45 minutes, and there's a lot of interruptions and poor connectivity. Sorry for that.
Yes,
But
sorry, sir.
at least,
Sorry, sir.
at least 38 people stick on to the last minute of the talk. That was really good. For want of time, we will wind up the discussion. Over to Roshni for a vote of thanks.
Thank you, sir. As we come to the conclusion of today's session, I would like to sincerely thank our program director, Dr. Rajkumar Ramaswamy, sir, and our eminent faculty, Dr. Rajiv Bhattacharjee, Dr. Prasanna Rammohan, Dr. Satvik Kadar, Dr. Manjula Rao, and Dr. Reshma Puranik for their valuable contribution. A big thanks you to all participants for joining us today. We look forward to your continued participation in our upcoming IIO Expert Insight sessions. Wishing you all a pleasant.
Good night, everybody. Bye.
Thank you.
Thank you.
Thank you.
Thank you all. A very good night.
Thank you.